Afternoon, everyone. For those of you who don't know me, my name's Patricia Osborne. I'm Chief Exec at the UK charity Brittle Society. I'd like to welcome everyone to our afternoon session on Covid-19 and OI. I'm delighted to introduce our panellists today. We are delighted to have Dr Kassim Javaid from Oxford University Hospitals, and he's also chairman of our charity's Medical Advisory Board. We also have with us Professor Nick Bishop, Sheffield University and Sheffield Hospitals Trust. Professor Bishop's also a trustee of the Brittle Society, and he's interim chair of our Scientific Advisory Board. I'd like to welcome them both and to thank them especially at this very difficult time, and to say that we do very much appreciate the work they're doing right now at the NHS. Would you also welcome our Support Development Officer, Corinne Kildea, who will be fielding questions throughout this session to the speakers, and she will be fielding questions which have been submitted by you, the OI community. So thank you. Over to you, Corinne.
Thanks, Patricia.
Thank you all for joining. Welcome to the call.
Thanks. Yeah, so firstly, I'd like to say thank you as well for everybody for joining, and also a big thank you to everybody who took time to submit questions prior to this. That's what we'll be using for the basis of today's Q&A. We did have a lot of overlap with questions, so I have tried to amalgamate them all so that we're not asking the same thing over and over again. I think it's fair to say we're certainly living through somewhat unusual times just now. So I'm personally really grateful that both Dr Javaid and Professor Bishop have managed to give us some of their time today. Firstly, just before we get started, I just want to go through some technical issues, technical features, should I say. We've muted everyone's microphone. That's just so we don't get any background interference. However, if you do want to make any comments or submit any further questions, you can use your chat button at the, I think it'll be at the bottom of most people's screens, depending on what device you're using. And if we've got time at the end, we will try and answer some more questions if any more crop up, okay? Also, we are planning on recording the webinar today, and we hope to get this up on YouTube at some point, possibly later on today or tomorrow. And then just as a final note, it's a bit of a disclaimer, this is an information session only, and advice given will be of a general nature. For any specific medical advice, you should always consult your own GP or doctor first. And that said, I'm not sure if either Dr Javaid or Professor Bishop have any disclaimers they need to disclose before we start. No.
Sure. So, hi everybody. You should know that over the years I've given advice to various drug companies about medicines to be used in osteogenesis imperfecta.
Ooh, what kind of drugs are we talking?
Those drugs would be medicines to make your bones stronger. So bisphosphonates originally 10 or so years ago, and nowadays the antibodies to sclerostin. So those are my disclaimers, and as Patricia mentioned at the beginning, I'm a trustee of the Brittle Bones Society.
Okay. So if we start with some of the questions then. So my first question, these have just come in from individuals, I've got them in no particular order really. How would I know I had COVID-19? And how soon should I ring the NHS 111 line? What advice would I expect, as I don't believe OI as a condition is on the vulnerable list? I'm not sure which of you want to answer that first.
Cass, do you want to kick off?
Yeah, sure. So first of all, I think the most important thing for anyone listening to this is to keep checking the NHS website. The information is changing daily or weekly. The main symptoms are of a fever. It's usually high, above 38 degrees, but can be a bit lower, so above 37.5, and a persistent chronic dry cough. Those are the two main symptoms, but there are other
shut up, I'm on a call, just leave me alone.
There are other symptoms that can happen, and they can happen before you get the fever or cough, and these can include symptoms of the bowel, such as diarrhea, And there is also this work on the fact that you can lose your sense of taste and smell. The NHS has got the 111 service, and if you are worried if you should contact the NHS, there is a very simple online questionnaire that you can take on the NHS website, and that should filter most people into whether they need to call for further information or can self-manage at home. The most concerning symptom is worsening breathlessness. So if you're getting breathless, and especially if it's getting worse, that is a warning symptom that you may need you definitely need to contact the NHS, and you may need to be seen on an NHS site. But as we learn more, there are new symptoms that are coming up that can precede the main symptoms of cough and fever. A very common symptom people have is extreme fatigue. It's particularly noticeable, and it is usually much worse than they've experienced with previous viral illnesses. But just to finish where I started, please just go to the NHS website. There's a really simple one-on-one online questionnaire, and that should take you through and actually pushes most people just to phone up and have a discussion. And all the GPs have been given advice now on the key questions they need to ask when assessing people who may have this infection over the phone or through a video consultation.
Great, thank you.
Okay, so from the pediatric children's side of things, you'll all be aware, I'm quite sure, that the majority of people who are getting really sick with this infection are older folk. So my age and older, essentially. And it's also those with particular conditions that have been listed. Those include things that are related primarily to diseases of small blood vessels, such as diabetes and high blood pressure. A lot of folk who've got diseases that affect the immune system have also been contacted, as have folk who've got pre-existing lung conditions, such as severe asthma, cystic fibrosis, and then diseases that are known to cause ongoing problems with your lungs, which are evident on a day-to-day basis. So in children, often this disease seems to manifest as a relatively mild viral illness, sometimes progresses to a chest infection. As Kassim was saying, for those who get the more severe form of the disease, it typically starts to get worse after about 5 days. So quite a lot of people have this initial viral illness with or without some respiratory difficulty. And then after about 5 days to a week, things get worse. And that seems to correspond to a change in how the virus and the body are interacting. So the body starts to react more severely against the virus after that period of time. So far in the UK, of the 7,248 people who sadly have lost their lives as of lunchtime today, only 5 have been children. Most of those children have had some underlying predisposing condition. If we look at the total number of cases reported worldwide, it's nearly 1.5 million people who've been diagnosed with the COVID-19 infection so far, and that's probably a gross underestimate of the total number of cases, because some countries like the UK have not been testing the general population. So at least 900 to 1,000 folk with OI, at least, are likely to have had this condition, this disease so far. We are not getting reports that folk with OI are at particular risk of either developing the disease, developing the pneumonia that goes along with that in its initial stages, or becoming extremely sick subsequently. Nevertheless, you'll be aware that there's been some advice that the Brittle Bone Society have put out and which Kassim and I have both had some input into. So we do think that for those of you who've got small chests or whose children have got small chests where there's existing lung problems that require additional support with oxygen or overnight ventilation or other forms of respiratory support, that you are at increased risk and that you should be considered to be in the vulnerable group. I think that's probably as much as I need to say at this stage in response to that question.
Yep, I think you've just answered my next two questions as well, which were, are children and young people with OI vulnerable to the virus, which I think you've just answered, and is the risk of complications increased from COVID with OI and scoliosis?
Well,
I don't know if you want to add anything else to that.
Yeah, I think it's probably worth adding scoliosis, which is a curvature of the spine, may be associated with altered respiratory function. If you've got a significant scoliosis and your chest is small, then I think that probably puts you at increased risk, certainly of the respiratory, the pneumonia, the chest infection part of the problem. Whether it predisposes you to the more severe consequences, the way in which the body then interacts with the virus and makes things worse with and the way in which that affects small blood vessels, I don't think we have enough information to say anything about that at the moment yet.
Okay. So my next group of questions are about fractures. What advice would you give to an OI patient that is currently shielding or isolating if they suffer a fracture? Would you feel an assessment in hospital through A&E for manufacturers is an unnecessary risk at this stage, and would you possibly recommend self-treatment at home where feasible to minimise exposure?
Yes?
Yep, sure. So I think, so for the adults, I think it depends on where the fracture is. And the bottom line is, if you're concerned, so you've got pain or other symptoms, then you should go and use your usual pathways to have the fracture managed. Fractures can cause complications that need early treatment, and by ignoring these, you can make the situation worse. We are working with our adult orthopedic colleagues to try and set up a network to see if we can make that better. And we are exploring options in emergency rooms for people sending advocates ahead of them to say, look, I've got a patient who's shielding, who's had a potential fracture, and maybe using video conferencing. But there are things like displaced fractures or damage to nerves, or very rarely blood vessels, and also complications around the fracture that do need someone with expertise to look at and assess before they can say it's safe for conservative treatment. Clearly, the capacity for the NHS to operate on fractures is changing, and it changes depending on where you live, and it will change over time. Many patients are still having routine surgery, whether it's felt that the risks of waiting outweigh the risks of potential infection. But that has to be done on a case-by-case basis.
Okay, and for children, it's very much the same. Most children who are suffering frequent fractures and are more severely affected with OI are already seen in one of the 4 designated specialist centres. What's tending to happen is that if a fracture occurs, they phone the folk that they would normally go and see. An assessment is made over the phone. A discussion is had to, as Kassim said, determine whether there are additional issues relating to either nerve or blood vessel problems. We've had a case this week where, in actual fact, one of our centres has sent people out to someone's home to see the child who is being shielded, and provided splints and advice over the telephone from the doctor about pain relief. So that's, that's all stuff that's in hand already. Fracture management in children, if it required operative management, the pathways of care are changing on a day-by-day and week-by-week basis, in general terms, you would revert to your normal provider. But in some areas of the country, children are now being advised to attend a regional centre rather than a local centre for acute management of things that may require surgery. So, for instance, in South Yorkshire, all children as of today who require operative management are being transferred to Sheffield Children's Hospital, irrespective of whether they would normally be managed locally or not. So these things are changing on a day-by-day basis. I should add to what I said earlier as well. For children, the fact that COVID-19 is causing relatively mild illness and not really resulting in severe problems actually is potentially causing us a problem in the provision of general pediatric services. And we are aware that a number of children have come to harm as a result of late presentation with diseases that are not COVID-19, but which did need management at an earlier stage. And the delayed presentation has actually resulted, sadly, in some instances in children dying with diseases that we would normally be able to treat quite quickly. And that's a problem for us. So if you've got a sick child, please do not delay in taking them to hospital, irrespective of whether they've got OI or not.
And the same would apply to the adults, Nick. One thing we're very concerned about is that the people without COVID are actually sitting at home and getting sicker. And the NHS still has the capacity to see these patients.
Yeah.
And many casualties are divided into COVID and non-COVID areas.
Yes.
So, you know, I know the Stroke Association has really put a strong message out, but does apply across the board. If you get unwell and you would normally go to A&E for other reasons, then that pathway is still functioning.
Yeah. And the same is true for children's hospitals. The accident emergency departments are divided into COVID-19 and non-COVID-19 areas, hot and cold areas, so that we cohort people away from the infected areas if we think they are free of the infection, and normal care pathways are followed.
Great, thank you. Dr. Javaid, you've already kind of touched on this, but I'll ask it anyway. Does the Medical Advisory Board and the BBS feel it would be of benefit to establish a single point of contact or offer bespoke medical advice to clinical staff on questions or concerns that they may have whilst treating an OI patient with COVID-19?
I think the best advice is to go to the medical teams who know you best. And I think that is the overriding benefit of the NHS. For those of you who do have specialist centres, there will be means by which you can communicate to the departments for non-urgent issues. Clearly, if there's an emergency, we have A&E and other pathways that work for that. But for semi-urgent or other questions, you will have a way to contact your team. They may be slower in responding, but they will know you best. And, you know, it's really important when we're making decisions about your care, we have as much information as possible, and that's why we would always recommend you go back to that point of care. We are developing regions, so we are following the pediatric model for children, and there will be in the coming time, I can't say when, regions where there'll be regional cover. But at the moment, I'd go back to the people who've seen you before and know a little bit about you, rather than to go a team who've never seen you and don't know your history.
Yeah, the same follows for pediatrics. We are more fortunate, I think, than in the adult services in that we do have in England the 4 designated Scotland centres, and in Scotland the centre in Glasgow. For Wales, Cardiff, and for Northern Ireland, Belfast, all have paediatricians who do provide some level of service for children with OI, and many of the patients in Wales and Northern Ireland are actually linked into one of the 4 designated English centres in any case for help and advice. And we're all just a phone call away. If you need us, we are here. In terms of the surgical provision, again, the surgeons all talk to each other. There's a good network of paediatric surgeons who discuss cases between them. So don't be slow in phoning up for advice and help if you want it.
Great, that almost kind of covers the next question, which is, please could you advise what general practice would be for a type 3 individual if hospitalisation is required at a centre where OI is not understood? What extra measures need to be taken due to the severity of the chest-shaped deformity in type 3, and could a transfer be requested to a centre with an OI specialist?
Cass?
At present, the NHS knows that people with rare bone diseases such as OI and with chest wall deformities are a special group. So the doctors know about that, and we are working with the orthopedics and the anaesthetists to move forward so they can understand what to do. The anaesthetists are actually quite a connected group, and they will talk to each other for advice. There's no formal process at the moment, but we have worked with NHS England, so the groups are identified. So the intensivists and anaesthetists should know that this is a high-risk patient who potentially, as Nick said, we've got no evidence, but potentially could have different consequences from getting a severe infection from COVID-19. Yeah.
And again, for children, I actually think it's more likely you'd need hospitalisation in a child with type 3 for reasons which were not related to the COVID virus. And so you would you'd follow your normal care pathway. If the hospital that you were going into was not one of the 4 designated paediatric centres for OI, they would liaise with us and we would discuss whether transfer was required or not, depending on what the reason for hospitalisation was. We do act as a sort of a national service in that way already. These are situations that only arise very rarely, and I think if you have those concerns, then speak to the treating team at the hospital where you are and get them to give us a ring.
Great. I would normally have regular bisphosphonate treatment. Should this still go ahead or should it be postponed?
Mm-hmm.
Nick, you first.
Okay, fair enough. Yeah, my turn to take the lead for a change. Okay, so what I would say about that is that we have been through, and I'm sure all the other centres are doing the same, been through our patient lists. We have contacted all of our families where we feel we need to, and discussed with them what their views are about continuing to have intravenous treatment, whether they want to come to us, whether they want to go to a local hospital, whether they would rather, if they're on intravenous treatment, move to oral treatment for a period of time with the understanding they might go back on intravenous treatment in due course. We've got a couple of ongoing research studies we've discussed with the folk who are in that, whether those continue or whether they revert to a more standard sort of treatment. In general terms, bisphosphonates are drugs which stick to bones for a while. And if you were to have to delay your treatment with an intravenous bisphosphonate for a while, it might be that you'd be more fatigued and have more aches and pains if you're still a growing individual. But generally, we don't think that would be a really, really big problem. But if it was becoming an issue, then we'd encourage you to talk to the people who normally treat you and have a discussion around what you do next. We have moved quite a number of folk who are on IV treatment onto oral treatment for a period of time with the help of our colleagues in general practice. I think in adult practice it's slightly different because we don't have the same problems with treatment sort of seeming to wear off over time. But Cass, you'd be better off talking to that than I am.
No, I completely agree with you, Nick. In the adults, it's a slightly different situation. And here, many of the units that are giving these intravenous bisphosphonates are being repurposed. There is a staffing shortage across the NHS and people are being redeployed, as well as staff sickness. So for that reason, most adult physicians would agree it's okay to delay the intravenous bisphosphonate for 2 or 3 months because they stick around for so long. And even if it's more than 3 months, it should usually be okay. the evidence base for intravenous bisphosphonates reducing fractures, which is the main reason many people are on them, is not as strong as it is in children.
Great. If you have severe kyphosis or scoliosis and your airways are compromised, i.e. neck at an angle, how easy would it be to ventilate someone and other ways to get oxygen into your lungs?
So the easy question. Right. If you've got severe kyphosis scoliosis, then that is a problem in terms of ventilating somebody, because it could be difficult to intubate them. You need somebody who's a skilled anaesthetist, who's used to dealing with airways that are difficult, and you need to be in a centre that's used to dealing with that sort of problem. Fortunately, there are relatively few people with that degree of problem, but my suggestion would be, if you are already known to a service and they know you and you have this kind of issue, then I would go back to them. As we've said before, it's much better to deal with the team that knows you already. Are there other ways to get oxygen into the lungs? Yes, there are two other ways. Really, you don't want to go there if you can avoid it. And you can have a very close-fitting mask and ventilate somebody with that. It's not very pleasant. It feels like you're being suffocated. You can have a tracheostomy, which is not a great solution, because you end up with a pipe going into your neck. And obviously, if you've got a severe kyphoscoliosis, often you'll have a very short neck as well. And then finally, there is the complete heart-lung bypass system called ECMO, which you would really only go for if there was no other way of oxygenating your blood. You really don't want to do that if you don't have to.
And I think Nick's highlighted a really important point. For people with severe chest wall deformities, the key is to avoid getting infected in the first place.
Yeah.
It is absolutely essential for those people who are really concerned about these issues that you fundamentally shield yourself and reduce your risk of infection. There are very clear guidelines on the NHS, and you know it's going to be a long haul. There are issues, but for some patients that when they go to have these sort of discussions, you have to weigh up the benefits versus the risks, and not everything works for every patient. So I would underline what Nick said. These are really not great second options, and please do shield yourself as much as possible. We've got very good data. This is a tricky virus. It stays around on cardboard, on metal and plastics for a while. You have to have a dirty and then a clean area. Wash your hands regularly. Avoid touching your face. If someone in your household has got it, you've got to stay away from them as much as possible. And if you've got people coming into your house because you need them because they're your carers, they should be wearing adequate equipment so they don't give it to you. As Nick said, these are really unsatisfactory second options if you've got severe chest wall deformities that we want to avoid as much as possible.
Thank you. I think that's really good advice. Would you consider an adult with moderate type 1OI to be in the higher risk group? There's mixed advice online about people with type 1 and the effects of collagens on the lungs. Is it possible this could put us at greater risk even if we've never suffered respiratory problems in the past? And are you aware whether different types of OI have different risk profile for COVID-19?
So as Nick has said, we're still learning. At present, from the evidence that we have, the main driver for complications is the shape of your chest. If you have an abnormal chest shape from a severe curvature of the spine that makes your lungs small, then that is a concern. For people with type 1 OI, that is usually not a problem, except in a very few as they get much older and have more vertebral fractures. I know there is growing evidence that the collagen mutation does affect the lungs, but we don't know yet whether A, that causes problems and whether it causes problems in this pandemic. So at present, I will be reassuring. We have limited resources and we should really focus them on the people at the highest risk. and that for me would be the ones with the people who are living with severe chest wall deformities. What do you think, Nick?
I'd absolutely agree with that, Kaz, and I think it's also worth just reminding everybody that the people who get sick, really sick with this, it's not that they are getting a pneumonia initially, and then they seem to get better again, and then they get worse. And the folk who are getting worse are folk who are significantly overweight, folk who have diabetes, and folk who've got high blood pressure, possibly due to problems affecting the very small blood vessels that permeate the whole of your body. And these, in those instances, it seems to be that something, that chemicals that the body is producing itself to try and kill the virus are actually causing more problems for the different organs in the body. So not just the lungs, but the kidneys, the heart, possibly in the long term the brain as well. This is what is being reported by the adult intensive care doctors, not just in this country, but across the world. So, as I said before, if you have those additional vulnerabilities, it is incredibly important that you try and keep yourself safe and keep yourself away from other people for this period of time. I think that's probably the most important advice that either of us can give anybody with OI is don't take the risk of getting the virus in the first place. So when we come down to, are we aware whether different types of OI have a different risk profile for COVID-19? I think we just go back to the things we've already said. Type 1, at the mild end of the spectrum, if your chest shape is okay and you don't have any other factors, you're probably not really at any greater risk than members of the general population, as far as we can tell at the moment. But OI is a relatively rare condition. It affects 1 in 15, 1 in 16,000 of the population. And even though there's quite likely to have been somewhere around at least 1,000 folk with OI who've had this bug already, in the grand scheme of things, that doesn't give us enough numbers yet to make clear statements about risks. So try not to take the risk in the first place if you can possibly avoid it.
When the kids return to school at some point, I'm sure the coronavirus will still be around in lower numbers. Should we keep severe OI children off school for longer?
My wife's a teacher, so I have to be very careful what I say. I would just follow the government guidelines. We're finding out more. As Nick has said, the main problem is getting adults infected. But as a parent myself, kids are a great way of getting infected. So that's all I'm going to say. Nick, what do you think?
It's very interesting because with another hat on, I'm actually Vice President for Science and Research at the Royal College of Paediatrics and Child Health. We've been very concerned about the effects of kids being off school on a variety of things like their mental well-being and all sorts. One of the unintended consequences of children being isolated has been that we've seen a huge drop in the number of children presenting with infectious diseases and coming to hospital. Very interestingly, so one of the diseases that people will have heard about is meningococcus, and you've heard about the glass test where you press on top of spots to see if they go away with a glass. The number of children presenting acutely with this potentially life-threatening disease has really dropped off. The number of children presenting with diabetic ketoacidosis, where they come in with very high blood sugars and unconscious and breathing very fast, has also dropped. So there's been some very interesting unintended benefits from having children off school, but we also are worried that in the long term this will have a detrimental effect on mental health and general well-being for kids. So watch this space. I think it's just so difficult to know at the present time what to advise, but I think the picture will become clearer as we get further into this. certainly for the time being, and my daughter is also a teacher, Cass, so she complains to us about the amount of work she's having to set for the kids to do online. So I'm sure the teacher will be quite keen to get back to school as well in the not too distant future, but we just have to wait and see at the moment.
Thank you. On a similar note, when the restrictions are lifted, how safe will it be for those with severe OI to go out again, bearing in mind there's still no vaccine available, and would wearing a mask offer any kind of protection?
So the answer is don't know, because we don't have enough information. Wearing a mask probably protects other people from you passing the virus on more than you protecting yourself from getting it. Masks are obviously being used. We are using face masks that are very close fitting in hospital with special built-in filters that help keep viruses out. Those are not masks that are available outside of the, for the general population. And yes, we are hopeful that a vaccine will come along at some stage. So to try and answer the question, I find that difficult at the moment because we don't have enough data. I think we'll have to wait and see what happens over time to the groups who are regarded as being vulnerable. One of the interesting things, though, has been that we haven't seen a lot of children being admitted who've got OI. We haven't seen a lot of children being admitted who are, for instance, on treatment for cancer. We haven't seen a lot of children who've had organ transplants being admitted. So some of the assumptions that we've previously made about who might be most vulnerable are not necessarily correct in the pediatric age group. And that's why I'm saying we need more data really at the moment.
Okay, great. If we have severe OI, is there any way to speed up getting the NHS letter? I currently still haven't received one, but I'm following the advice that I'm in the vulnerable category. And similarly, should children be receiving a vulnerable person's letter?
So for the,
go.
Yeah, I'm sorry, Cass. For the children, we've just recently, in the last 24 hours, had a letter sent to us through the highly specialised service group for NHS England that we can send out for children. So we'll be getting onto that after Easter. At the present time, the advice is simply keep yourself safe and shield as you would do, assuming that you are extremely vulnerable. For adults, Cass, I don't know whether you've been sent similar letters that you can send out for yourselves or not.
Yeah, so I want to be really clear on this. It's an emerging area, and it's not quite sorted out at the NHS end. But as we've posted on the Brittle Bone Society website, there is a web link where you can declare yourself as needing shielding, and you can fill in that form. What then happens is that form triggers someone at NHS to contact your GP, and the GP then can confirm whether or not you should be shielded. At present, that system is what's been recommended, but there is another system coming in where each hospital has been asked to identify all of their high-risk patients who will need shielding, and that is what Nick is talking about. However, that will take, I think it will take a while to work out, because you've got to go through all the patients, you've got to put them on this list, and then goes to a designated COVID-19 doctor in your hospital, and then it goes to NHS England. So at present, there is something you can do. You can register online. You don't have to call anyone. And then once you've done that, you should be somewhere in the system of needing help. The main reason to do this is if you are shielding and you need help with food, essential food and medicines or other areas, it gives you access to the volunteer army. And that's the key sort of link in there. So I would push the NHS. They've said they provided it as the online form. We put it up. And if people are having problems with that, then do get in touch with us.
Thanks. Could I possibly just add to that, Dr. Javaid? I think those guidelines for registering are just for England. If you're in Scotland, go to
Okay.
the Scottish Government website and there's a
Okay.
separate process. You need to register locally. Just to make that clear. Okay.
Still one nation
Yeah.
for now.
For now. On a similar note, I'm an essential worker and caring for a child with severe OI. What should I do? It states to isolate him for 12 weeks and I've not had a letter.
Say that again, Corinne.
I'm an essential worker and caring for a child with severe type 3 OI. What should I do? It states to isolate him for 12 weeks and we've not yet had a letter. So basically, this is someone who's an essential worker needing to go to work, but she's got a very vulnerable child at home.
Okay. I think I would go back to what Cass was just saying. Register online, and then hopefully that'll give you access to some further support services.
And I think if you are having to go outside of your home, which we will designate as a clean area, you have to be particularly careful about wearing PPE, hand washing, avoiding touching your face, and avoiding getting yourself contaminated with the virus. Some people are putting pillowcases in their inside their front door. When they come in, they get changed, put the stuff in the pillowcase, and it goes in the wash. And then you get changed and cleaned, and then you can go back in the house, and then you can go into the house. And that's what some essential workers are doing. It might seem as overkill, but really, if you've got a very vulnerable person at home, do as much as you can to stop that virus getting a link into the house.
So we've actually had advice from the hospital yesterday to do exactly that. To take, to strip off when we get home, put everything in the laundry, and change into normal clothes.
Okay, on a similar note, for those of us with personal carers coming to our homes, is there anything else we could be doing to protect ourselves that would help with the risk of getting COVID?
So Nick, please go.
No, I was going to say, Cass, I think you wanted to say about vitamin D.
Oh yes, so I'll talk about vitamin D in a bit, but for people who have carers, there is now guidance from social care, as I understand, and there is guidelines on PPE protection, so they don't infect the people that they're caring for, and that should be followed. That's what the guidance has come out in England, and we hear on the daily updates about this. What Nick was mentioning was vitamin D. Most of the adults, if they're in specialized centers or centers, will know about this and be tired of taking these vitamin D or calcium supplements. It's not quite clear if this is important, but there is some information that has been done in people without COVID-19 showing that if you have very low levels of vitamin D, you are more likely to get influenza-like infections, and giving you vitamin D reduces that risk. So we're sort of making a jump to say it's not a good idea to be vitamin D deficient if you're vulnerable and during this pandemic. And usually for adults, this can be easily treated with over-the-counter preparations, or if you're already on vitamin D supplements, just keep taking them. I don't think it helps once you get infected. I think by then it's just probably too late. And there is some work at NHS to see whether this is something that we should be promoting, because the last thing we want to do is promote things that don't have the right evidence and sort of take our eye off what's really important. So that's the information we have at the moment for adults. Nick, did you want to add anything for the children?
No, I think that covers it effectively, Cass. I think the situation for children is just the same. I mean, it's all about avoiding risk, and in terms of personal carers coming in with the vitamin D, pretty much all of the kids that we look after, we advise them to take vitamin D on a regular basis anyway. And it's something that we've grown to do over the years. So most children will be taking either a multivitamin or a vitamin D tablet on a regular basis anyway.
caregivers, such as parents, are often asked to assist hospital staff in moving and handling of patients with severe OI for various reasons. Do you think, do you believe that the hospital may exercise discretion on allowing a caregiver to be present if relevant PPE is used, or will there be a need to possibly issue new guidelines and potentially educate hospital staff on handling patients with severe OI?
So for children, they would turn, if they were in one of the designated centres, they would turn to us anyway, the team that would normally be providing the care. So I think it depends if they are being managed outside of one of the designated centres, the 4 designated centres where most of the kids with severe OI go, then I would expect the doctors who are managing the patient in that situation to contact us and ask for our advice and help.
I would echo what Nick says. This is an extremely contagious virus, and we need to keep as many people uninfected as possible.
Yeah. All right, and finally, my last question. Do you feel the decision-making tool recommended within NICE guidelines for those not being assessed by the clinical frailty score has enough safeguards and depth to assist clinicians in making well-informed decisions on who gets access to critical care beds or ventilator support when patients could potentially be competing for limited resources?
So that is a very important question, and I know has raised a lot of concerns, fears, and worries in the community. Fortunately, at present, and I'm not making any predictions, for some reason, the number of people requiring ventilation in many hospitals is lower than we anticipated. And the reason that's important is the supply issue doesn't today seem to be an issue. And that if you are going to benefit from ventilation, you will probably be offered it. The key point is the risks and benefits of ventilation, and that has to be done on a person-by-person level. This frailty score that has been used is important and has been used in people aged over 65, but we have pushed the NHS to be very clear this is a guide, and we still need adequate clinical input where the doctor looks at the whole patient and can make a valued decision with the patient and their family. And that's the importance of going to people who know you very well. It's not an exact science. It's based on experience and the expertise we get from treating this virus and knowing what its complications are. But at the moment, and I hope it stays that way, the supply issue doesn't seem to be a big problem today.
So, yeah, and on the paediatric side, the clinical frailty score is not applicable to children. We expect, based upon both discussions that we've had internally within the college and with NHS England, that there will be modified guidance being issued in the not too distant future. We expect that that guidance will do exactly what Kassim's just said, which is that every patient will be assessed as an individual and there will be no discrimination on the basis of disability against anyone. So I think that's a really important message to get to people, because obviously if you feel that you're going to turn up to hospital, they're going to take one look at you and say, well, clearly we can't help you. That's not going to be the case. Okay, it is really important. If you are poorly, go and seek medical advice in the way that you would do normally, in the expectation that you will be managed appropriately. Okay, don't delay on the basis of being concerned or worried about that. And as Kassim was saying, you know, we are some way away from getting towards the peak of the epidemic, I think. But even so, we're not seeing the sort of the overwhelming of our service in the way that the Italians have had, or the Spanish. Our critical care capacity in the UK has been increased substantially, and we are nowhere near what we can deliver yet. So please do not be afraid to go and seek advice if you need to.
Thank you both. That was the last of my questions. I don't know if either of you feel there's anything else you want to add to any of those. Dr. Javaid, I'm aware you've got another appointment at 4 o'clock, so we're kind of running out of time.
Yeah. So
Trish, I don't know if you want to add anything.
No, I just saw the comment from Penny about PP to agency carers and not being available. People employ their own PAs. I would actually contact your local authority. They may be able to advise. I mean, it's in everyone's interest that PP is given to those that need it. So if there is a problem, you should contact people who are doing it, and most local authorities will have some contact point for this.
Great.
Nick.
I was going to say, actually, Corinne, I think there was right at the beginning, there was a question that somebody had sent in beforehand about surgery needing to be postponed, and which kind of got, I think it got jumped over. So the honest answer is pretty much all elective surgery currently for children has been cancelled. There's very little elective surgery going ahead. It's only emergency work that's being done, and therefore there will be a backlog, and people are going to have to wait longer, unfortunately, to get the surgery that they need. So, for instance, we had a discussion earlier this week with one of the children, well, the parents of the children who will need surgery, or where surgery had been planned and is going to have to be postponed by probably 2 or 3 months. And that's unfortunate, but in each case, I think the important thing is to have individualized discussions with the treating surgeons about what needs to be done in the meantime. It's not there won't be a one-size-fits-all approach to how this is managed. It will be on a case-by-case basis. Sorry, Cass.
And I've just seen a very important comment by Natasha. We've talked about the physical aspects. This is having a tremendous impact on the mental health of both people with rare bone diseases, their families, and also people without rare bone diseases and their families. Mm-hmm. And there is support for this available on the NHS website, and there are lots of online social media tricks or advice or templates, things you can do to keep your mental health as good and as solid as possible. This is going to be a long time in this situation, and we need to make sure that the environment and the families as positive as possible, and we can all work together for this.
Thank you very much. I have tried to have a quick skim through some of the questions people have asked. If there's anything we haven't covered and has not been answered, please just email me directly. You can either get me at corrine@brittlebone.org or email admin@brittlebone.org, and we will try and answer them, after this if anybody's got anything that we've not covered. Thank you again, Professor Bishop and Dr. Javaid. I think that's been really, really useful. As I say, we are recording this. We hope to get it up on the website later on. And I think that just leaves us to say thank you very much. Have a lovely Easter, everybody, and make sure you stay at home.